So I will be introducing myself. I am Karell Calpito. I will be your facilitator for session 1. I am a medical doctor, researcher, public health practitioner, and an SRHR advocate. I have been part of programs and projects around adolescent sexual and reproductive health with extensive experience in health policy and health promotion. I am a program officer working on the Safe Abortion Initiative at the Asian Pacific Resource and Research Center for Women, or ARO. We are a regional NGO based in KL, Malaysia, working towards achieving sexual and reproductive health and rights for all. Before we start session 1, I'd like to do a quick poll using our chat box. We have a very varied audience in this room, and this poll is just in multiple choice format. And you can type your answers in the chat box. And as a warm-up, I'd like you to type start in the chat box. Thank you. Isabel, Mariana, Sandy, Abu. Okay, thank you. I see that everyone's awake now. We can proceed with question 1. So question 1, medical abortion or MA is carried out using A, misoprostol, B, mifepristone, C, both A and B, or D, I know of a new drug used in MA, and you'll have to type the name of that drug in the chat. Okay, very good. I see Isabel, Christina, Serena. Okay, I see a C of C's, letter C. And the answer for this question is C, both A and B. I haven't seen anyone answer D, and that's okay. So question 2. Which of the following is considered obsolete as a surgical abortion procedure? Vacuum aspiration, A, dilatation and evacuation, B, or dilatation and curettage, C. Question 2. Okay, I see again a C of C's. Thank you. The correct answer is C, dilatation and curettage. Question number 3. Ultrasound is mandatory in determining the age of gestation or in determining how many weeks is the pregnancy. This is a true or false question. Just type in your answers. Ultrasound is mandatory. Okay. I see this time the answers are divided. I see some true and some false. For those who answered false, you are correct. So ultrasound should not be mandatory in determining the age of gestation. Thank you. That was just a quick poll. I just want to see that everyone's already listening and everyone's in. We can now proceed with session 1. Before we dive into the discussion regarding abortion, this is what we'll be covering for today. Session 1 is on what is abortion, the methods of abortion, the global burden of unsafe abortion, and how is abortion a human right. So we heard in each other's introductions today that we come from different backgrounds, different countries. So before we go into a more discussion on abortion, I'd like to establish a foundation. So the topics that I might be discussing here may be something that you already know. So please be mindful that not everyone in this room will have the same knowledge and background and experience as you. So you'll have to bear with me as we'll go through everything as a review or maybe something new for others. So let's start with the definition of abortion. So medically, this is defined as the termination of pregnancy or the expulsion of the conceptus before 20 weeks of gestation. However, the popular use of the term abortion by the general public refers to the termination of pregnancy, whether it occurs with a medical intervention, either through medications or surgical procedures, or whether it occurs on its own. This is called a spontaneous abortion, or more commonly known as a miscarriage. So the World Health Organization deems abortion as a safe and non-complex healthcare intervention that can be effectively managed using medication or a surgical procedure in a variety of settings, but taking into consideration that the methods recommended by WHO have to be appropriate to the gestational age and or by the providers in safe setting. So broadly, the methods of abortion are grouped into medical and surgical. So we start off with the medical. Medical abortion is abortion carried out using medications or without any surgery. This is recommended usually for gestational age less than 12 weeks. As mentioned in the earlier quiz, this refers to question 1, and you were all correct. Most of you were correct, I think, in naming that mifepristone and misoprostol are the most common drugs used for these. So the protocol for mifepristone and misoprostol, when both available, is it is used sequentially, and this is detailed in Table 1 on the left side of your screen. However, there will be some countries and some settings that do not have mifepristone available. Therefore, only uses misoprostol alone. This protocol follows Table 2. Medical abortion, also the routes of administration of misoprostol is according to the following. So it could be done orally when pills are swallowed immediately. Buccal is when pills are placed between the cheek and gums and then later swallowed after 20 to 30 minutes. Sublingual is when pills are placed under the tongue and swallowed after 30 minutes. And lastly, vaginal, when pills are placed in the vaginal canal. So this is the medical abortion update. In the latest 2022 WHO abortion care guidelines, they now introduce an alternative medical method using letrozole in combination with misoprostol. However, this is a suggest status in the WHO guidelines. And in WHO guidelines, suggest means that it is a weak recommendation, but it is in favor of the intervention. So overall, letrozole is more readily available in some countries because it is used in infertility and cancer treatment. Also, it is of low cost, so it is a good alternative to mifepristone when not available. WHO also recommends self-management of medical abortion in early gestation. This refers to less than 12 weeks. So as recommended by WHO, as you can see on your screen, 1, 2, 3, it can be self-managed, all of the 3, or just partly with the guidance of a provider. So the first is the assessment of eligibility. This is taking into consideration determining your pregnancy duration and or ruling out the contraindications. And then next is the administration of the medications outside of a healthcare facility and without the direct supervision of a trained provider. And lastly, the assessment of the success of the procedure. So in the latest WHO guidelines, the recommendations that do not just cover medical abortion in early gestation, but also now include the use of many contraceptives post-abortion. Okay, we've finished the medical methods of abortion. We now proceed to the surgical. For the surgical methods of abortion, this is the use of a minor surgical procedure to carry out an abortion. This procedure can be done as an outpatient, meaning you don't have to be admitted for the procedure. One of the methods under surgical abortion is vacuum aspiration. This is recommended in less than 14 weeks. This can either be electric vacuum aspiration or manual vacuum aspiration. The only difference is in electric, you'll need an electric vacuum, which is the blue contraption on the screen. Another method under surgical is dilatation and evacuation. It is deemed the safest and most effective surgical technique for later abortion, which is gestational age greater than or equal to 14 weeks. Although the recommended methods of surgical abortion at later gestations are demarcated at 14 weeks, there is actually flexibility in the use of one surgical method over the other between the gestational age of 12 to 16 weeks. So the one on the right pertains to our question number 2 in the quiz earlier on dilatation and curettage. This is a procedure where the cervix is dilated using special instruments called dilators, and then the walls of the uterus are scraped using a sharp instrument called a curette. And so DNC has higher complication rates than vacuum aspiration, and is also deemed more painful for the person undergoing it. Therefore, it was considered obsolete by WHO last 2012 and was reiterated in the 2022 guidelines. We have services across the continuum of care, meaning these are services before, during, and or after the abortion procedure or process. So providing information is one, and informed consent is obtained only when we provide complete and accurate evidence-based information. And that should respect the privacy and confidentiality of the patient or client. And the right to refuse such information when offered must be respected. Number two is provision of counseling. You have to make it clear that counseling is not required and have to ensure privacy and confidentiality, and that counseling should be non-discriminatory and non-biased. This pertains to question number three, the determining gestational age of pregnancy earlier, that WHO recommends against using ultrasound scanning as a prerequisite, meaning that you will not provide the service unless they undergo an ultrasound. It is not always necessary, and it is recommended to use the least invasive method that is appropriate in the circumstances and available in the setting. We can determine gestational age of pregnancy through by counting days from the last menstrual period or from the uh, last sexual interaction. But some cases may still require, but should not be a prerequisite to providing the abortion service. Antibiotic prophylaxis, this is important for surgical abortion. This prevents infection, meaning it is recommended to be administered before or during the surgical operation. Lastly is pain management. This should always be available and administered in advance. This is in anticipation of the onset of pain or should be provided to the patient in case it is needed for later use at home. So although abortions are extremely safe when done with the right and comprehensive information and or performed by a trained provider, like all medical and surgical procedures, there is always a small risk of complications. And these complications could be hemorrhage, infection, or incomplete abortion. Hemorrhage refers to excessive bleeding that may occur when there are retained products. Products here refer to the products of conception, and injury or infection. Infection is rare when the surgical procedure is performed by a trained provider and in safe conditions. And in the event of an incomplete abortion, a re-evacuation should be performed. As to long-term effects, contrary to popular belief, there are no adverse effects on subsequent pregnancies. And all persons having an abortion should be given clear instructions before going home, both verbally and written, on what to expect and how to recognize danger signs that will need coming back to the health facility. So post-abortion care is important to avoid any morbidity and mortality after an abortion procedure. In restrictive settings, this is very important as after an unsafe abortion procedure where appropriate post-abortion care can mitigate some of the effects of the unsafe procedure. So the objectives of post-abortion care is to ensure adequate follow-up of the person who has undergone abortion, to ensure early detection and management of any complications, and to counsel and or provide post-abortion contraceptive services. It is important that the service providers on the ground are equipped with the knowledge and to recognize the signs and symptoms of the complications of unsafe abortion and to know where to refer the patients in case this happens. So either in their communities or in the framework of their health system. So a person undergoing medical abortion should always have access or referral to emergency care in case this becomes necessary. So following a safe abortion, a routine follow-up is not necessary unless the person faces any of the complications that we have discussed in the previous slide. So we've finished the first two, which is the review on what is abortion and the methods of abortion. At this point, do we have any questions? Um, it's also okay if you don't have any questions or you'll need time. You can type it in the chat. Uh, we can move on to a very short break. Please come back in after 5 minutes. This is just a quick stretch break, and we can proceed to the other half of this session. Hi everyone. I hope you're back. Please type back if you are, or just turn on your video quickly so I can see that you're back to your desk. Thank you. Thank you, Isabel, Serena, Lina Faye, Christina. Okay, I see. A lot of people are back now. Okay, so we'll resume. Hi, Abigail. Thank you for joining us. Uh, While maybe waiting for others to join in too, let's do again a quick activity. For those who can turn on their videos, please do. And if you know this TikTok trend, it's put your finger down. So I just want you to show one hand, any hand, it doesn't matter. And for any of the statements that I read out or flash on screen, if it's true for you, in your opinion, put your finger down. Okay? Okay, so put your finger down if the statement is true. Okay? In your opinion, this is a safe space. We're here to have these conversations. People will seek abortion regardless of what the law says. Put your finger down if this is true for you. People will seek abortion regardless of what the law says. Okay. Almost every death and injury from unsafe abortion is preventable. Criminalizing abortion makes abortion less safe. Criminalizing abortion is a form of discrimination. Last, abortion is a human right. Okay. So far we have 5 statements on the screen. Let me know how many fingers you've put down. You can just type it in the chat. I can see Teresa and Farah. Thank you. Thank you for joining in. Okay. Wow. I see a majority of us are on the high end of numbers. This makes it easier for the next sessions. Thank you. Oh, thank you everyone for joining in on the activity. I hope you're energized again, and we'll proceed with the second half. We have the global burden of unsafe abortion and how is abortion a human right. So, according to global estimates, 45% of all abortions are unsafe. This makes it a critical public health and human rights issue. 97% of these unsafe abortions are in developing countries. So in numbers for young people, 3.9 million girls aged 15 to 18 years undergo unsafe abortions each year. And 4.7 to 13.2% of all the maternal deaths are attributable to unsafe abortions. And almost every abortion death and disability could have been prevented. So around 7 million women are admitted to hospitals every year in developing countries as a result of unsafe abortion. And the annual cost of treating major complications from unsafe abortion is estimated at, wow, at 553 million US dollars. So many pregnant people, including and especially young people, find it difficult or impossible to access quality abortion care. Why? This may be due to restrictive laws and policies, poor availability of services, high cost, stigma, conscientious objection, unnecessary requirements, and for young people, may be age, gender, and or marital status. So what happens then when they cannot access safe abortion? They resort to unsafe methods. And just to note that in the world's abortion laws, the legal WHO and the Center for Reproductive Rights reiterate that the legal status of abortion makes no difference to a pregnant person's need for an abortion. Instead, it affects access to safe abortion. So I have only a few of the stats here. As you can see, there are still 26 countries that prohibit abortion under any circumstance. And one of these 26 would include where I am right now, which is the Philippines. If you're not aware of the abortion laws in your country, Please check this out. I have pasted the link in the chat box below. Also, to note that not a meaning it doesn't mean that illegal is unsafe. There are some restrictive settings wherein our advocates and providers still find ways to provide safe abortion services to those in need. So how is abortion a human right? The right to decide whether or not to continue with a pregnancy is a basic human right. This is endorsed and supported by several international consensus documents, and every woman has the recognized human right to decide freely and responsibly without coercion and violence the number, spacing, timing of their children, and to have the information and means to do so, and the right to attain the highest standard of sexual and reproductive health. This is from the ICPD in 1994. I have put an asterisk on woman because although most available evidence on abortion can be assumed to be derived from research on the study populations of cisgender women, we also recognize that cisgender women, transgender men, non-binary, gender fluid, and intersex individuals with a female reproductive system and capable of becoming pregnant may require abortion care. So then, access to legal and safe abortion is essential for the realization of these rights. Young people, especially, are often considered incapable of making their sexual and reproductive health decisions. This would mean that their guardians are making life-altering decisions for them, like marrying them off, continuing an unwanted pregnancy, or marrying them off before they reach adulthood. So reproductive rights, including access to safe abortion, is essential to the enjoyment of a wide range of other human rights. This includes the right to health, right to life, right to freedom from torture and ill treatment, right to privacy, education, equality, and non-discrimination. So it is a form of gender discrimination to refuse to provide legally for the performance of reproductive health services for women in need of it, and to punish the same women who seek these services. This is gender discrimination. And the non-provision of safe abortion services is a violation of the rights of pregnant persons to health and life. So criminalization of abortion, denial or delay of safe abortion and post-abortion care, and the forced continuation of pregnancy are forms of gender-based violence and gender discrimination. More specifically for young people, these are from the general statements from the Committee on the Rights to the Child of the Child CRC in 2016 states to decriminalize abortion so that girls can have access to safe abortion and post-abortion services, and review the legislation with a view to guaranteeing the best interests of pregnant adolescents and ensure that their views are always heard and respected in abortion-related decisions. This then puts safe abortion services under the umbrella of universal access to sexual and reproductive health. So SRH information and services benefit individual and community health and contributes to the realization of human rights. So the WHO, in light of the pandemic, has included comprehensive abortion care in the list of essential health services. Also strengthening access to comprehensive abortion care within the health system, this answers our sustainable development goals, more specifically SDG 3 and SDG 5. Excuse me. So WHO has released its 2022 abortion care guidelines just last 9th March. And they have reiterated that access to quality abortion care is the cornerstone of this guideline, wherein quality abortion care has the following components. It is effective, efficient, accessible, acceptable, patient-centered, equitable, and moreover, safe. So then the recommendations cover legal, health system, and community levels, and respect for human rights, including a supportive framework for law and policy, the availability and accessibility of information, and building a supportive, universally accessible, affordable, and well-functioning health system. So again, let's proceed to a quick activity. I will be sharing the Jamboard link in the chat box. Please open it on your end if you can, and we'll meet there. Okay. If everyone has ever accessed our a Jamboard before, you can just click on the lower left. This is the sticky note, and add in what you think are barriers to young people's access to safe abortion services, and keep it on the left side of the screen. So one example I've already mentioned earlier was age. Feel free to add your sticky notes here, or if you can't access the Jamboard link, you can type your answers and I can help you move it to the Jamboard. I'll give you 5 minutes for this. I'll just watch people put in their answers on barriers to young people's access to safe abortion services. Uh, yes, if the left side of the screen is not enough, it's okay to spill over. But for now, as long as the whole screen is filled with barriers to young people's access to safe abortion, so that you're not restricted to one side. I did not foresee that everyone would fill the board. Thank you. Oh, thanks, Charity, for that. Thank you. Thank you, everyone. I can see that there are a lot of answers on the screen. We have lack of information, uh, age, cultural barriers, sex ed, conservative environment, third-party authorizations, myths, lack of political willingness, discrimination, restrictive laws, lack of privacy, stigma, policy not accepted by the government, prejudice and cost, lack of information or the places to access it, inequality, health worker discrimination, parental consent laws, religion, lack of awareness, not having access to information, okay, taboo, and political religious facilities are far, yes, not inaccessible. There is also strict laws by the government. Yeah, I found that. So there are some that criminalize abortion. Thank you. Thank you everyone for putting in your answers on the Jamboard. Let me go back to. Thank you. So yes, regardless of law and policy, communities and systems may still be unsupportive of young people. Uh, because young people face multiple facets of discrimination, that then restricts them from accessing sexual and reproductive health services, especially of safe abortion care. So the stigma on young people's sexuality is a huge barrier. Young people have the right to access the full spectrum of reproductive health care services. This includes contraception, comprehensive sexual education, maternity care, post-abortion care, and safe abortion. So there should be recognition and respect of young people's bodily autonomy and choice. This is where a rights-based approach is important. The provision of these services for young people should recognize their ability to make their own decisions about their sexual and reproductive health. So then protecting these young people should not be about denying them of the services or information, but rather it be about providing youth-friendly sexual and reproductive health and rights services and policies that support compassionate, humane, stigma-free environment. So the right to decide for your own body is not actually simply about sexual choices and reproduction. This then trickles down to the whole self. It includes the dreams and the potential of the young person. So every individual should be empowered to claim their bodily autonomy. This includes men, women, boys, girls, and people with diverse sexual orientations and gender expressions. So then, true gender equality means that everyone can pursue whatever career or lifestyle choices that you want without discrimination, without coercion, and without violence. So, well, that's a wrap up. We have done the abortion definition, the methods of abortion, discussion on the global burden of unsafe abortion, and abortion as a human right. I am sharing the references for this presentation. Feel free to browse it at your own convenience. And also, if you have any questions or comments or reflections, you are free to share right now. If you can type it also on the chat. But I have an assignment for this group. So after the discussion on barriers, looking at the Jamboard that we all filled in with the barriers, I will be making a page 2 for I want you to share at least 1 to 2 strategies that would help create a youth-friendly and supportive environment around access to safe abortion. It's in the same Jamboard. I will be creating page 2 for that. And you can leave your answers there. There will be a more in-depth discussion on barriers to access. Barriers to access. Okay, is the assignment understood? This will be used in that session, in the barriers session. Also, just introducing Yana. Yana is a small network currently that has about 100 members who are affiliated to and engaged in reproductive rights and justice. We have a range of individuals from all around the world who are committed to fostering a community of young, safe abortion advocates and activists. So if you want to join Yana, I am also pasting the link form in the chat. Thank you. Thank you for your attention and participation.
Thanks, Karell. Does anybody have any questions for Karell? I think that's a pretty powerful slide.
I know it failed it. So I'll be creating page 2 for the assignment. Um I'll make this into page 3. Give me a second. Page 2 is for the assignment. Page 3 is for you to leave your questions in case you'll have them later on after mulling over what we've discussed. You can leave your questions, comments, and or reflections here on page 3 of the same Jamboard. That's all. Thank you.
Okay, thanks, Karell. I just want to say one thing. We'll be having the next session on next Friday, which is the 25th of March at around the same time. And when we meet in the next session, we would like you to come after having done this assignment that Karell has given today. And if possible, also talk to your colleagues or other friends, peers, etc., who you may want to discuss this issue with. So, for example, youth-friendly health services, if you want to discuss this with your other colleagues or peers, and then want to come back and share your experience, that will be very welcome. And if there are no questions, then I think we are good to close, and we'll see each other next week then. All right. Thanks, everyone.